Can I welcome everybody to the last session of the day? Well done for staying right to the end. That's fabulous. I'm Sue Hayward-Giles. I'm one of the Assistant Directors in Practice and Development, the professional body part of your membership organisation. And I'm delighted to be here hosting the abstract sessions this afternoon. Welcome to those of you who are joining online. Please do put your questions, get them ready in the Q&A function. And the programme order, I would just like to clarify for everybody. We are going to start with Brooke Nairn from the University College London as a change to the running order, and we're going to take questions directly after Brooke's presentation. We're then going to move on to the 4 remaining presentations. So if you're looking at the conference booklet, we're actually not going to have the presentation by Hayley Carter. So just to clarify, there are 5 presentations and Brooke will start first, and I'd like to invite you up. Thank you very much.
Thank you very much, and hello everyone. As Sue mentioned, thanks for sticking around to the last session. So my name is Brooke Nairn. I am a research physiotherapist. I'm also completing my PhD at UCL on the Telerehab project. And some of you may have heard of it already on Thursday, and we had an exhibition stand yesterday where we were showing the technology of the system. So I'm just going to share some preliminary work, specifically regarding how we are refining the telerehabilitation decision support system for persons with stroke and how we've adopted a very patient-centric approach. And yeah, I'll work through that. So next slide. Do I have the clicker?
The green triangle should take it forward.
There we go. I had the exact same problem on Thursday. There we go. So, bit of an introduction. As many of you may know, stroke is the leading cause of adult disability in the developed world, with many residual effects, balance and mobility being a very common one, affecting about 85% of persons with stroke. A lot of the current post-stroke rehab programs are not comprehensive, they're not always individualized, and unfortunately, this leads to poor patient outcomes and high dropout rates. So using this evidence and addressing these gaps in the research, this is where the Telerehab decision support system comes in. So this is an AI support system, and it uses augmented reality to deliver remote physiotherapist-led balance rehabilitation. So the preliminary research I'm just going to talk through in the next few slides is specifically regarding the qualitative focus groups we've delivered, and the aim of that was to collect feedback from both patients as well as clinicians to help refine the system so that it is stroke tailored, it's individualized, and it's also comprehensive. So addressing these gaps that we've identified. And so how did we do that? 2 focus groups were delivered. This is, again, preliminary. We've done another 3 focus groups, but 2 were conducted last year between February and June. 5 semi-structured interviews, open-ended questions, and then we used thematic analysis to review the results. And so what we found, we had 9 clinicians, and this was primarily physiotherapists and 2 neurologists. There was quite a range of experience, which is fantastic because we got a mixture of opinions and perspectives. They were all in the specialty area of neurology and or vestibular rehab. And then as for the persons with stroke, we had 7 participants. They were between 50 to 80 years of age and in the chronic stage, which is specifically the eligibility criteria for the trials that we are running. So following these focus groups, we identified 5 common themes and 14 sub-themes. And so if we start with the exercise considerations, there was a lot of additional exercises that were proposed, and that was one of the questions we specifically asked for, and so that has been integrated into the new platform. And specifically, of course, with this population, a lot of stroke-specific exercises needed to be included because the previous project of which this is developed on, it was called HoloBalance, and some of you may have heard about it, and it was just designed for those at risk of falls, whereas now we are making it a lot more specific to stroke, mild cognitive impairment, vestibular dysfunction, and long COVID-19 dizziness. I'm not going to go into details about all the other cohorts because I'm focusing on the stroke aspect. But yes, we've included additional exercises, including toe raises, heel raises, identifying, hemiplegic weakness on one side. And so from first impressions, the exercise instructions were lengthy and complex. And this is something we have also identified and refined in the new platform that's going to be delivered in January. But both clinicians and persons with stroke found it was a very engaging system. There was really positive uptake of it, and they could really see themselves using it. And one participant specifically said, I think every trust is a bit different. And she had found that when she was discharged from the hospital, she didn't get much care afterwards. And she's like, if I had a system like this, it would have been fantastic to do at home. I can connect with the physio. So this was positive to hear. Of course, there are barriers to implementation. I think anybody working in transformative technology, digital innovation, can probably appreciate similarly. Equipment burden, setup burden, and this is specific because this is a remote system. So there is a minimal requirement to be able to set this up, and there may be assistance that's needed. And so addressing this, we have actually changed our technology a bit, taking into consideration this feedback to make it more simple, easier to implement, but of course there's certain criteria such as needing a care and someone around. Program suggestions, so we've refined and made our assessment more comprehensive, essentially, to gather as much possible information we can for informing the protocol, the rehab program. We've addressed fatigue management and fall safety. So it is augmented reality, not virtual reality, which of course is, for many, maybe some of you know, augmented reality, you still see your environment. You see the chair, the table, everything around you, but you have an overlay. So this is much more safer than, say, VR, which just encompasses your entire visual field. And in regards to patient use, they had said, we would need motivation to use the system. And of course, it needs to be individualized, I think, as every physio knows. And so there's a patient mobile app, and this is going to have their rehab program, kind of, like a calendar with the dates, motivational prompts, badges, to keep them motivated, and they'll also be able to contact the clinician through the app. So, in conclusion, there is mixed opinions, of course, and the primary findings were that we need additional exercises that are stroke specific. We need to simplify the instructions so that they're clear and easy to follow, especially, of course, in a stroke cohort. And we need to implement technology that is simple to set up. And again, I think we can all recognize this working in the field with patients and depending on the population. So these findings, they've already actually been implemented into the new system, as I mentioned, that's rolling out this January. So we've changed the tech, the instructions. We've refined the system quite a bit. And then just as a highlight for those that may have noticed during the methods, there's a bit of obviously sample bias based on who responds to the focus groups, but we need to make sure that it's more inclusive in regards to ethnic diversity in the focus groups, which was quite a limitation we addressed. This clinical trial is going to be delivered in Thailand, Madeira, Greece, Germany, and UCL. So we are really trying to get a representative sample and see how the system is rolled out in multiple populations. And I think that is it for me. These are just a few of the quotes from both clinicians and patients. And of course, I'm a small part of the project. There's lots of individuals contributing to this. And of course, I'd like to thank my professor, Doris Eva Bamu at UCL, and Dr. Nezat Kuhi. So thank you all for listening, and that's it for me.
Thank you, Brooke. Questions from the floor?
Thank you for a really interesting presentation. I just wondered, in the focus groups, how did you actually introduce the technology to the patients, and what opportunity did they have to sort of try it out and play with it to make a judgment on it?
Yeah, great question. So we first showed them a video, which we had developed that had, all the instructions of how to perform the exercises. It demonstrated all the different games, because we have standard exercises that are delivered with a virtual coach via AR, cognitive games as well as extra games to make it a bit more interactive. And then we had the tech for them to touch, feel, try on. And so we got feedback from them, yeah.
Question at the back of the room?
Thank you. That was a really good talk. My question is in relation to your next steps, and the countries that you have involved is really diverse and really impressive. So my question is specifically, how have you found the governance and procedures and policies, etc., for setup in those countries?
Yes, big question. So I'll elaborate on a bit of what I know, but so within this project, we have 15 partners involved. And we have partners dealing with the AI regulations, with the tech, with the coding, the hologram. That's not me. I'm more on the clinical side of informing it based on a physio's perspective. But obviously, each clinical site has undergone their local ethics. They've registered the clinical trial based on their local body. And then in regards to implementing it with, say, following AI regulations, I can't touch too much on that as I don't want to give false information, but our partners essentially who is responsible for that liaise with each clinical site individually and say, based on the guidelines in your local area, you have to have X, Y, and Z in place. Does that answer your question? Sorry, it's not my area of expertise in the project, so I can't dive too much into it.
Any questions online? Can I ask a question?
Yeah.
Do you have any data relating to either cost effectiveness or any benefits in terms of cost?
Yeah, no, I'm glad you asked that. I obviously, with limited time, I couldn't go into all aspects of the project, but one of the key things we're looking at is affordability. So we have partners who are doing a socioeconomic analysis, and we also have a tool implemented in the platform that will look at the staffing, and the infrastructure as well as the equipment available at each local site. So, I think that's important to consider. What's the budget at each clinical site? What's actually available to make this feasible? And so that is taken into consideration. So if a site, say, has less funding, has less equipment available, that AI support system will say, so we have this available, this is the most efficient use of it. And one of the aims is to make more feasible and efficient use of the healthcare system's resources.
Fabulous.
Yeah.
Okay, can I ask you another question?
Yes.
In terms of accessibility and inclusivity, just thinking about the population who were using the tool, have you got any data relating to its application to those groups who may find access difficult?
Can you, sorry, I don't think I understand fully.
In terms of the population who are using the tool, are you collecting any equality data, inclusivity, accessibility for different population groups?
Yeah, absolutely. So with the previous project that this is built on, so HoloBalance, of course, they did feasibility and acceptability studies. And we are also liaising with a gender and equal opportunities officer. So we are collecting all of that information to try, of course, it depends who does reach out to want to participate in the project, but we are aiming to have a really inclusive sample, and we're going to collect, very extensive data regarding various ailments, gender, ethnicity, geographical boundaries. Unfortunately, I think one of the limitations will be, so for us, for example, in London, we only have a certain boundary that we can do this initial study in because we have to travel to the site to help them set up the equipment if there's troubleshooting issues. So there's a bit of bias there and restriction there, and that's something that we would hope to expand once we know the platform's up and running. But we have an officer actually in charge of that to make sure we address that.
Thank you. Any other questions? Fabulous. Please join me in thanking Brooke for her presentation.
Thank you.
Thank you. And now could I invite Richard Husselby onto the platform, please? Richard is from Birmingham Community Healthcare NHS Foundation Trust. Thank you, Richard.
So good afternoon. Yes, my name's Richard Husselby. I work as an MSK consultant physiotherapist in Birmingham. And I'll be talking to you about evaluating the impact of a digital therapeutic to a community musculoskeletal waiting list. So more than 20 million UK residents have MSK conditions, and prevalence is increasing. Post-pandemic, the backlog awaiting access to services has increased. NHS England is leading an initiative to embed digital technology in support of self-managing MSK conditions, and partnership working with the private sector offers exciting opportunities for achieving this. Get You Better is a commercially available digital self-management support tool helping patients to self-manage their condition and build capacity into the system. The purpose of this study was to evaluate the impact of Get You Better to a community MSK waiting list, with the specific aims of assessing rate of uptake and use, to evaluate user experience, and to compare the rate at which users and non-users remove themselves from a waiting list before accessing physiotherapy. A mixed methods approach was used to evaluate impact. Between January and June 2023, all patients on a community MSK waiting list were sent a postal invite for Get You Better. In July 23, the total number of downloads and the frequency of use was reported. In April 23, 3 months into the project, a convenient sample of 239 users at that time were emailed a questionnaire exploring outcomes and satisfaction. In July of 23, the rate at which users had removed themselves from the waiting list prior to attending physio was compared to non-users for the same period. Concerning results, uptake and frequency of use, of 14,500 invitations for Get You Better, just 657 patients had downloaded and used it. This is 4.5%. Of these, 395, 60% had used it just once. But 138, about a fifth of the users, did so 3 or more times. Concerning the response to questionnaire, of 239 patients canvassed, 7% responded. A fifth of these said Get You Better had helped to improve their pain. A quarter said it helped them to return to usual activities, including work. Confidence about self-management had improved, and the app had helped them to understand their condition and recovery journey. 7 users reported not needing any other treatment. There were favourable comments too, but 12 users, 71%, were critical of limited content regarding their specific condition, with chronic osteoarthritis and hypermobility mentioned. Of 408 users cross-referenced with the waiting list, 284, 70%, had removed themselves before attending physiotherapy. This was 30% above the rate of removal for non-users. And the key to these graphics, I guess, is for those users of Get You Better, most removed themselves from the waiting list before attending physio. For non-users, most attended physio. In conclusion, sending postal invites for Get You Better to a community MSK waiting list resulted in a limited uptake. For patients using it, some did so 3 times or more, reporting that it helped them to relieve their pain, return to activity, improve confidence in self-management, and better understand their recovery journey. However, some users were critical, complaining that it had not targeted their specific condition, particularly for chronic presentations. Get You Better helps some patients recover without the need for physiotherapy or other support, and it has shown some potential for reducing a community physiotherapy waiting list. In summary, Get You Better has had a positive, albeit limited impact. It has reduced the waiting list modestly, but it has seen to improve user confidence in self-managing conditions. Clearly, further work is required to explore methods to increase uptake and maximise that impact. And the concluding slide is to highlight the 3 key impacts. Get You Better can improve confidence. Get You Better demonstrates potential for reducing waiting lists, but the use of postal invites certainly isn't supported by this study. Thank you.
Thank you, Richard. Can I have any questions from the... Oh, quite right. I was full of my own questions I was going to ask you, Richard. Can I introduce Ben Foxcroft from Leeds Community Healthcare NHS Trust? Thank you.
Thank you. Hi everyone. So yeah, my name's Ben. I'm going to present some of the work that I did as part of my pre-doctoral fellowship. That was funded by the NHR, which you'll see their logo above the salmon line at the top. So I'm going to talk about greater trochanteric pain syndrome. So it's a really common cause of lateral hip pain, and it'll affect 1 in 4 women over 50. And these patients really struggle. So they have comparable disability and pain levels to people with severe end-stage osteoarthritis. And it also has a really poor natural history. So one study with an 11-year follow-up found that 45% of patients still had symptoms even after that amount of time. And 40% of patients that were referred to a musculoskeletal service had failed to improve with physio and injections already. So these patients, they require a lot of resource in terms of appointments, and there's also a lot of investment required from the patient to get to the appointments, to park up, etc. And that's where virtual consultations could come in and help this. So virtual consultations exploded during the pandemic when obviously we couldn't see each other. As the restrictions have been removed, obviously they've decreased, but even last year, 25% of consultations in primary care were still delivered virtually. And GTPS is a bit of a weird space where when we did a survey of practice, and 90% of interventions that were delivered commonly by physios were non-physical, and that was mainly education and exercise. So we're not doing much manual therapy and electrotherapy, etc. And so it could be delivered virtually. But the question that we had is, can physios actually deliver that, and do they think they can do it? So we did an online survey and we disseminated this via Twitter. And what we were looking at was physios in the UK that treat people with GTPS who had experience of virtual and face-to-face consultation styles. We asked standard questions of demographics, in particular their level of qualifications and their confidence in tech. We asked them about their working practice and what their makeup of face-to-face versus virtual was. And then we asked them what their perception of their effectiveness with each consultation style was. And we graded that on a Likert scale, 5 being very effective, 1 being ineffective. So we did that overall, but then we broke it down into the constituent parts of rehabilitation of exercise, education, and self-management. The reason we did this is that we hypothesized that there would be elements of virtual practice that would translate and elements that we couldn't do. So in terms of the results, I'll work around from the top clockwise. So we had 383 views on the survey with 54 full responses. A limitation of our survey was that we had quite a skewed sample. So you'll see that we had a very qualified sample with 57% having over 10 years experience and 46% of people had a PhD, which might not be reflective of the typical MSK department. So just bear that in mind with these results. Also 40% of people had a self-declared interest in GTPS, which again, may not be reflective. In terms of working practices, so we found that before the pandemic, most people were either exclusively face-to-face or had a little bit of virtual. After, almost everybody had some virtual part of their practice. And then in terms of the overall findings, so we found that face-to-face was superior. That scored 5 out of 5 and virtual scored a 3 out of 5. And in terms of the associations of what clinician factors would predict you being more likely to say that you preferred virtual practice, we found that having a high level of postgraduate education and that a greater confidence in technology was associated with that. Interestingly, having an interest in GTPS and your level of experience and where you worked didn't have any association. And then we broke it down into the constituent parts. So you'll see the little asterisks indicate statistical significance. So for all aspects of exercise and most aspects of education, face-to-face was clearly superior. And I've ranked these in order. So at the top, you'll see that, for example, check-in exercise technique, there was a big disparity of 5 out of 5 face-to-face and 2 out of 5 virtually. But as you get down to the bottom, you see areas where they were still statistically significant, but the clinical significance is unclear. So virtual practice still scored a 4 out of 5, with 5 out of 5 being your most effective. So areas such as deciding on exercise parameters, discussing flare-up management, advice on modalities and lifestyle changes actually did quite well with that. And so what we took from that was face-to-face is still clearly the superior way of delivering rehabilitation for patients, and that in particular coaching technique and building that therapeutic relationship, that suffered the most virtually. But things like discussing flare-up management, providing follow-up support, signposting to different areas, that could quite easily be achieved virtually. And that's where we see its role going forward. And yeah, in terms of the association, staff that had a higher level of postgraduate education and confidence in technology were more likely to be able to adapt to this different consultation style. And that's me. Thank you.
Thank you very much, Ben. Can I now invite Diane McMahon onto the stage? Diane comes from Southern Health and Social Care Trust in Northern Ireland.
To the mic? Okay.
Thanks, Catherine.
Thank you for the opportunity to present my project here today. My name is Diane McMahon. I'm a physiotherapist working within the musculoskeletal outpatients team within the Southern Health and Social Care Trust in Northern Ireland. My project is called Takeaway and Replay and is a physiotherapy-led project on maximising technology to optimise outcomes in acute ankle sprain management within minor injuries. We know that lateral ankle sprains are the most common foot and ankle injury for which individuals seek medical care, and the most recent clinical practice guidelines in 2021 recommend that clinicians should implement rehabilitation programs with structured therapeutic exercise that can include protected active range of movement, stretching exercises, neuromuscular training, postural re-education and balance training, both in clinic and at home, as determined by injury severity, identified impairments, preferences, learning needs and social barriers. It came to light at the point of triage of referrals to our musculoskeletal outpatient service that patients who were attending minor injuries service were not receiving this evidence-based management at the earliest available opportunity, with data collection demonstrating that only 19.4% of patients with lateral ankle sprains were receiving an exercise-based intervention. Our current minor injury service within Daisy Hill Hospital is run by a group of emergency nurse practitioners. An opportunity therefore existed for physiotherapists to optimise evidence-based exercise rehabilitation within this group. Nationally and locally, there is a strategic drive to provide technology-driven and digitally mature options to promote patient self-management and support care delivery. The aim of this project was to carry out an intervention which ensured that more than 80% of patients received the optimum evidence-based management at the earliest opportunity using a digital resource for their lateral ankle sprain by October 2023. A quality improvement project was undertaken and a five-step improvement approach was applied. Baseline data was collected retrospectively for a period of 12 weeks in which the notes of all patients attending the minor injuries unit with a lateral ankle sprain were reviewed to establish the issue of an exercise-based programme. Quality improvement aims were identified and stakeholder engagement activities were undertaken with both staff and patients. A questionnaire was issued to patients on preferences of how they would like to receive their exercise-based intervention, and staff engagement activities included process mapping, rich picture, driver and fish diagrams to understand the challenges faced by staff. As a result of these patient and staff engagement activities, a number of themes came to the fore. Nursing staff identified knowledge, confidence in delivering exercises, resources and ease of documentation as barriers to delivering exercise within minor injuries. Patients reported written and video-based resources as their preference. I undertook 2 PDSA cycles based on the findings of the improvement activities and stakeholder engagement. The first PDSA centred on staff education on the best evidence-based management of lateral ankle sprains, and previously used exercise leaflets were updated. This saw an initial improvement in exercise issue, with the average climbing from the 19.4% to 50% within 12 weeks following the PDSA cycle. The second PDSA cycle was then undertaken with 2 objectives in mind. 1, to establish a more user-friendly, digitally accessible electronic resource, and 2, to ensure that the documentation was as easy as possible for staff. To this end, a video was produced and a QR code generated to enable quick and easy access to practically demonstrated exercises. And this was then produced on a centrally perforated sticker, where one side was issued to the patient and one side could be placed within the patient record. In completing this, it gave easy access to a digital resource, but it also made documentation a very easy and accurate process. And following introduction of the second PDSA, a steady improvement was demonstrated, taking the issue of exercise to over 80% of patients and achieving the quality improvement aim. This slide demonstrates the journey of data collection from baseline collection in October 2022 through to September 2023. A time series analysis, the heavy black line shows the average as we move through from below 20% initially up to the mid-50s after implementation of the first PDSA, and then rising over the red dotted line of the 80% as we move on through. In conclusion, over the 38 weeks on which the project ran, 1,067 patients with a lateral ankle sprain attended Daisy Hill Hospital. They were included in the data analysis, and the percentage issued exercises for their lateral ankle sprain increased significantly during that time period. And we postulate that as a result, and in line with the literature, that in ensuring this early intervention at the correct point in the patient journey, there will be less reattendance, better recovery outcomes, and less chance of the development of chronic ankle instability within this population.
Thank you very much, Diane. Please come and join us. And I'd like now to invite Helen Gooch from the University of Central Lancashire. Thank you, Helen.
So, hi, I'm Helen Gooch. I'm from the University of Central Lancashire. I'm a physio by background. I work as a research assistant at the university, but I also continue to do a day a week in private clinical practice. This work that I'm going to talk about this afternoon was completed as part of my master's in clinical research. And this was looking at how behaviour change is used within digital rehab for upper limb rehab early post-stroke. So we know that post-stroke impairments of the upper limb can really compromise function, and that recovery, early and intensive rehabilitation is key to recovery. So engagement in this early and intensive rehabilitation will necessitate some behaviour change from the patients to be able to engage with it. And as therapists, we really need to be considering how we are actually incorporating that behaviour change into our interventions. So the third part of this puzzle is, or a third part of the jigsaw around this scoping review, was that digital health technologies are being used more and more within stroke rehabilitation, but they also offer additional opportunities to try and influence and change patients' behaviour. So the aim as this work was conducted as a scoping review, and the aim was to explore the use of behaviour change approaches in digital health technology based interventions for the upper limb in the acute and subacute phases post-stroke. So in that is basically the first 6 months after stroke. So the scoping review followed the Joanna Briggs Institute guidelines. A comprehensive search strategy was developed and run through 6 databases. I decided not to put the time since stroke into the search strategy, as this was going to be quite difficult to identify that information in a search strategy. So the time since stroke was very much looked at during the screening process. So the search identified 1,402 sources, and these were screened against preset eligibility criteria. Of those 1,402 sources, only 4 ended up being included, only 8, ended up being included in the final review. So the most common reason for exclusion at full text screening was that studies were not conducted within that 6-month window. And this is something that is actually reflected in other reviews looking at upper limb rehab in stroke, but it's quite a concerning finding really that we're not doing work that's actually focusing on those critical early months following stroke. So the data was charted, the interventions were, the behaviour change techniques within the interventions were coded based on a taxonomy called the behaviour change technique taxonomy. That could be a whole another presentation in itself, but it essentially consists of 93 individual behaviour change techniques which are clustered into 16 clusters. So what we found was all the studies were experimental in design, and the majority of them were feasibility studies, so suggesting that work in this area is in its infancy. All interventions consisted of either one or two different types of digital technology, and all of the studies were either virtual reality or activity monitors with a 50-50 split. And activity monitors and virtual reality weren't used in the same intervention. The activity monitors were worn daily, whereas the VR was more conducted in a number of sessions, and the total interventions had quite a big range, so between 2 and 12 weeks. So looking more specifically at the behaviour change, the first thing to note is that there was no behaviour change theories, models or frameworks that underpinned any of the interventions, even though there were clear behaviour change techniques within those interventions. When looking at the behaviour change techniques, it was summarised by looking at the numbers of clusters that could be seen within the different interventions. Each cluster was only represented once per intervention, even if there was a number of individual different techniques within that cluster that was identified. And as you can see, all 8 interventions included the feedback and monitoring cluster, so elements of behaviour change techniques linked to feedback and monitoring. And then the graph on the left of this slide is just looking in a bit more detail, drilling down to the difference between the activity monitors and the virtual reality, looking at the proportion of behaviour change techniques that were identified within those 2 types of technology. What we can see, unsurprisingly, we have quite a big percentage in both for feedback and monitoring, as shown in the orange. But for the activity monitors, the other 2 areas of behaviour change that came out more strongly was the goals and planning, which is shown in the navy blue, and the associations, which is shown in the lighter green. And associations, behaviour change techniques were linked to things around prompts and cues. Whereas with the virtual reality, there was a much stronger use of the reward and threat cluster. But I have to make it clear that it wasn't threat that was included in that, but it was very much reward-based behaviour change techniques that were being used. So just to conclude, we need more research in this area early post-stroke. Interventions need to really be able to clearly articulate how they are expecting the behaviour change to work and the theories and models that are underpinning that. And whilst this study tells us maybe what behaviour change techniques are being used in different types of technology, it's not, it was very much a scoping review, so it wasn't looking at effectiveness, and more work is needed to understand the effectiveness of different techniques, but also within different types of digital technologies.
Thank you, Helen. Thank you. Please come join us. Opening up to questions from the floor and from online. Yeah, Catherine, thank you.
Thank you. So this is a question from me, actually. Just to start with a question to Helen around the behaviour change techniques that you described, and whether you could kind of contextualise those for people. So give an example of what feedback and monitoring as a cluster look like in an intervention.
So obviously it was quite hard in that time to go into some of that detail. The feedback and monitoring was very much about maybe apps, or say you had activity monitor that was linked to an app, and that was providing them with information about maybe how far they were walking, how much they were moving their arm. So giving them feedback about amount of use, there was some sort of feedback. Some of the VR gives you feedback on sort of quality of movement as well, and how you're using it. The reward was often things like scores. So the reward that was linked much more to the virtual reality was often scores, and that sort of social reward. Congratulations, you've managed to achieve this. As I said, the associations was more like prompts and cues, and that was more linked to the activity monitors. So that might have been monitors that wrist watches that say vibrated when it was picked up that somebody hadn't used their arm for a certain amount of time, to try and prompt them to use it. Is that a bit
thank
clearer?
you. That's
yeah.
really helpful, just to, because I know that, for example, the behaviour change technique taxonomy is quite abstract sometimes, so for us to think about what that means in terms of what something might look like.
There's quite a lot, as I said, there's 93 techniques. Trying to code the interventions to the techniques is quite challenging, and it is probably open to a bit of subjective interpretation, but it was trying to work out as close as we could what we thought they were trying to achieve in the interventions.
Thank you. I also have one question for David, is that if that's allowed. Just regarding the Get You Better system, and kind of reflections on the postal invite and how that kind of didn't generate as much uptake as maybe you'd hoped, and just whether you had any ideas about how you could reach those populations in the communities for this digital intervention or self-management tool.
Thank you. So this was a pragmatic retrospective evaluation of a piece of implementation work that was done at pace across an ICS with a post-COVID chronic waiting list. There was not a great deal of planning that went ahead into this, or indeed influence at a local trust level. We were part of an ICS, and some of the key learning was working across an ICS, I might add. And probably the least favourable choice of getting an app out to a chronic waiting list of people having been waiting for a year would have been a postal invite. The money was to support digital distribution of an app that had proven efficacy elsewhere, so that was a given, if you like, with no ability to influence IT to get this out in any other way than postal invites. So it was the least best scenario. The reasoning at the time was thought to be it would be better to offer people a little bit of something than all of nothing. But I felt there was learning there because it wasn't successful. I think sometimes, you can learn from your failure, and sharing what hasn't worked with others was important. And and I'll finish by saying I feel it was important because I was reaching out to colleagues in other ICSs nationally at the time who had deployed Get You Better in a similar way and had subsequently discharged their waiting list as a result of issuing the codes. And it's clear that if you follow these guys up, not that many people were using it because the implementation science hadn't been put in place. In fact, probably needs to be sold at the front door better by a trusted person in primary care to land, and we didn't do that. I hope that's answered the question.
It has, thank you. And thank you so much for kind of being honest and realistic about what you found, because exactly as you said, sharing that helps others to learn, and we don't always need to kind of gloss up and say, it's achieved this, when we need to understand what didn't work as well as what did. Thank you.
Thanks, Richard. Thanks, Catherine. Any questions from the floor? Anything online? Okay, I'd like to ask you, Diane, whether you have any information about the cost benefits of the work that you did?
No, we haven't done any formal evaluation of the cost benefit. I think probably with the fact that we'd have to go retrospectively to find out, you know,
Yeah.
look at the referral rate pre getting out the QR code, and look at the referral rate following it, and maybe even the number of appointments people are requiring before you've been able to give them the early intervention, in comparison to the benefits of getting an early intervention and maybe the reduced appointment need after that. So I think there probably is a bit of work that you could do there to look at the value of it, but no, we haven't done that just at this point.
Okay, interesting, thank you. And Ben, I wonder if you could say something more about, are you planning any next steps with this work? Are you taking any learning to implement into practice?
Yeah, so I'm planning to do a doctoral fellowship, and this was just a makeup of that. So the doctoral fellowship will be some sort of randomized trial, and part of that rehabilitation will be an arm of it. And I guess it was just how we could deliver that. And this told us that face-to-face is clearly the superior option, but that we can use virtual aspects to check in on them and follow them up and just give them that motivation, because parts of it will be lifestyle change about diet and weight management, all them kinds of things. And that obviously isn't just going to change with one appointment. So yeah, it will feed into a larger randomized trial, but not specifically to digital and virtual rehab.
Thank you, thank you. Any questions from the from the audience? Okay, I don't know whether any of you have any sort of comments or anything else that you wish to particularly say. I think one of the things that I've absolutely taken from this is that there is a huge opportunity and huge potential in terms of the use of digital healthcare technologies. But actually, there needs to be a lot of exploration, a lot of testing. It has to be local as well in terms of the populations that you're trying to access and create changes within. So I've found it really interesting to hear the work that's been done. So I want to thank you all very much for your presentation. Thank you. Just before we close the session, you can all go from stage if you'd like to. Sorry, the screen's in my way. Just before we close the session, John Cowman, the new Chief Executive of Chartered Society of Physiotherapy, has done a concluding video. So Tech are going to play the video for us as a conclusion for today and for conference. But I want to thank you very much for attending and staying until the end. Thank you.
Well, hello everyone, and that brings the CSP Annual Conference 2024 to a close. What a fantastic few days throughout the Students' Conference on Thursday, and then the main conference yesterday and today. I've had an absolutely wonderful time, and this job has always been a huge privilege for me, but never more so than meeting with members and over the last few days, and just seeing the energy and the quality that exists within this profession. I've loved meeting so many of you and being able to spend some time talking to you, understand where you're seeing the profession, and helping me and the CSP to make sure that we use our time, our resources, and our energies in the right place. The presentations were absolutely fabulous, and as somebody who spent quite a deal of time in academia and research, seeing the quality of those presentations and the content of them was really heartwarming. But also just soaking up that warmth and that vibrant atmosphere that existed over the last few days. And I know that exists every day within this profession. And I wanted to thank you for that. And I hope that you feel the same. And I hope that you feel that it's been really valuable being part of it. Ordinarily, I would sign off now with a breezy see you next year, but this year is, I have something more to add, because not only will we be back next year, but it'll be the first step on a brand new 4-year-long journey around the UK. And I am very clear that the CSP is a UK-wide organisation serving members across all 4 countries, the Crown States and the Isle of Man. So the next year, we are going to see you again, but it will be in Wales, and it'll be in Newport to be exact. In 2026, we will be in Scotland, and then we will go back to Northern Ireland and to the UK and to England. I've heard great things about last year's 4 conferences, but this is different This is bringing the whole of PUK in all its glory, in all its size, in all its scale to the 4 countries. Everything you have seen and heard over the last 2 days will be matched and hopefully exceeded. And I am not going to be shy about saying it, that we really want the countries to almost compete with each other to have the very best conferences that we can have. These days that we get together and the amount of work that goes into these days justifies it being really the very best it could be. And I would love to see you all there, because whether it's in Wales or England or Scotland or Northern Ireland, this will be your conference for your profession. And so please make sure that you see it as such and join us for those conferences and get to know different local jurisdictions, what the pressures are in those countries, and meet colleagues there who will be really proud, really happy, and really full of energy in welcoming you. So as I say, this is the first time we have ever done this, so I mean it more than ever when I say to you, see you next year in Wales. Thank you so much, and thank you for all your involvement.